Good morning. It's good to have you in our classroom in Carrollton. This is the lab, so welcome this morning. We're going to be talking about IV therapy. Now, if you have your handout that was published on Canvas, it would be great for you to print that out and have it beside you so you can take notes as we go through this. IV therapy provides both fluids and medications. Most every patient that you will come in contact with in the hospital will have either a saline lock or have an IV that's infusing. IVs are required for many conditions. The patient may be dehydrated, they may have problems with eating, or they maybe have nausea and diarrhea. There may be a problem with their blood sugar. It might be hypoglycemic or hyperglycemic. And these are some of the conditions that your patient may be experiencing and need an IV. And certainly if they have fluid and electrolyte imbalances with their vomiting and diarrhea, they would need an IV. Now you will be learning more this summer about fluid and electrolyte balance. So this will just be a little bit of supplementary material to what Dr. Locke will be teaching you. The goal of IV therapy is to restore or prevent the fluid and electrolyte imbalances, and also to normalize the lab values. Of course, we want to be able to have IV therapy without the complications. To have IV therapy, you have to have an IV catheter. Now, this is normally started by the nurse. If you have to have a central catheter, this will be inserted by a medical doctor. IV fluids can either be intermittent or continuous. So let me explain that. Remember we were talking about having an IV piggyback? So that would be an example that's something that would be intermittent. The doctor has ordered a particular time frame, like every 6 hours, every 8 hours. So much of this antibiotic needs to be given to the patient. And then when it has completely infused, you would disconnect that from the patient and just leave it in the room, the tubing, until time for the next bag of antibiotic. So that's an example of intermittent. Continuous means the IV fluids are infusing in the patient continuously, 24/7. Okay? Now, the nurse is responsible for monitoring this IV infusion every 2 hours. Every hour would be better, but in practical terms and from personal experience, I know that the every 2 hours works out much better for nurses. If you were in the intensive care setting, then you would be monitoring much more frequently. To be able to function in this role of an IV nurse, you have to have a basic knowledge of anatomy and physiology. You need to understand about pathophysiology, about chemistry, and you need the technical skills to be able to actually insert an IV into a patient's vein. Reliable access to an IV is a very basic necessity of medical care. As I said earlier, all those different conditions that a patient will definitely need some IV fluids, or even having the saline lock in just in case something goes wrong. We hope not, but it's always good to have that vein already accessed in case of an emergency and we need to get fluids into the patient quickly. The technical skill is quite involved because of sterile technique. Catheters use sterile technique when they are put in, so you have to be very meticulous about scrubbing the injection ports and keeping the IV catheter sterile and cleaning the site before you insert. There's just a lot of different things that you've already been exposed to through these videos of using your alcohol or your chlorhexidine gluconate to clean. Also, to lower the risk of complications, it was important to make sure that your IV tubing lines are clear of bubbles. So we want to make sure that that is taken care of as well. A nurse needs to have professional accountability. Know your role as a nurse in maintaining your IVs, making sure they're done in sterile technique, and decreasing the risk of complications. When my niece was a baby, she was in the hospital because she had rotavirus. And she was ordered an antiviral med, and it was given into her foot. She was not of walking age yet. So it's a very common sight for children who are not walking. But to make it more secure, the nurse wrapped it in Curlex gauze. Wrapped it round and round, was very secure. Now remember I said you need to at least every 2 hours inspect that IV. You want to look at that site, you want to see if there's any drainage, any redness, any swelling, making sure there's no complications of phlebitis or infiltration. Even if this IV site is wrapped in tons of gauze, or maybe even on an IV board. I know it seems like a lot of trouble to unwrap that every 2 hours and take a look, but you must do that. Well, going back to my niece, she had been in the hospital a couple of days and no one had checked that IV site. But then the accountability nurse came in, the one that has professional accountability. She came on duty and she did what she was supposed to, and she unwrapped that IV and saw that it had infiltrated. And this medication caused her to have a 3rd-degree burn. And she's in her early 30s now, but she still has a very deformed foot because of that burn that she received. So let's be very careful. Let's be that nurse that has professional accountability and check the IVs as often as you can, at least every 2 hours. We have agencies that I'm going to mention. This is not in your textbook. This was in our earlier textbook that we used, but I want to mention these to you. The Infusion Nurses Society, OSHA, the CDC are agencies that will give guidelines for infusion therapy. Also, Congress passed the Needle Stick Act, which requires facilities to have safety devices. And then we have our Nurse Practice Act that is for each state to determine who can start IVs. I know when I first graduated from the W in Columbus, LPNs were not allowed to even do IVs at all. But it's my understanding now that if they take a certification test, that they can start IVs. Okay, we talked a bit about isotonic, hypertonic, and hypertonic when I was showing you how to prime your tubing and doing all of that earlier this morning. So I don't see any reason that I need to go back over that. Just remember, if it's below 240, that's hypotonic. If it's above 340, that's hypertonic. And any of those numbers in between is isotonic. We do need to know that when a person receives, say, normal saline, that's isotonic. Remember, that's the particular fluid that is closest to our blood. When that patient receives that fluid, it stays in the blood vessel. So if your patient has low blood volume or low blood pressure, that would be a good fluid of choice to use. Now the hypertonic fluids draws fluid and electrolytes from the cells. So it draws it from the cells into the blood vessel is where it goes. So that would be useful for a patient who has had a severe loss of blood or plasma, such as a major burn or hemorrhage. Hypotonic fluids, on the other hand, they remove the fluid from the blood vessels into the cells. Hyperglycemic conditions are some situations where you would see this used for a patient. But the key is to replace fluid that is lost with a fluid that acts on the appropriate fluid compartment. So you've got your blood cells, you've got your blood vessels, you've got your interstitial compartments, which is your cells outside of your blood vessel. So you have to know if you need blood to stay in the vessel. Do you need, I said blood, I meant fluid. You need to know if your fluids need to stay in the vessel. Does it need to go out of the vessel into the cells? Does it need to go from the cells back into the blood vessel? Okay, before you initiate an IV, there are several assessments that you need to do. You're going to need to check the medical record to see if the patient has any renal disease, congestive heart failure, because this might indicate some particular fluids. For example, if a patient has liver disease, you would not want to give them lactated ringers because the lactation is a protein, I believe it's a protein, but anyway, it's metabolized in the liver. So that would be something that if the doctor happened to overlook that you would be able to catch that. So if your patient has liver disease, stay away from lactated ringers. Also, you'll need to check for allergies. See if the patient is allergic to shellfish, iodine, the chlorhexidine gluconate, also known as CHG. You may see those initials. Alcohol, latex. Those are all things that you will be using or possibly use when you're starting your IV. And then, of course, always check for medication allergies. You will need to look in the medical history to see if your patient has had a mastectomy, if they have got an AV fistula or a shunt for dialysis, or if they have had a stroke. So those are some things that may affect, because if you've got, if a patient is missing, say, the left breast, more than likely there have been lymph nodes that have been removed. So you would want to use the other side, like use the right arm to start an IV. If a patient has had a stroke, you want to start an IV on the side that was not affected, because if he does not have much feeling in that arm, he may not be able to alert you to discomfort. And so it's just always best, if possible, to use the opposite side. We want to check the patient's lab values. We want to look at the sodium levels, sodium and potassium, the hematocrit, the BUN levels. So this could indicate possible dehydration or having too much fluid. Also, if they're having problems with their bleeding, you would be aware when you start your IV that you may have increased risk of bleeding. Before you start the IV, continue to look in the chart and see if there is a surgical procedure or maybe a radiology procedure. I'll get that word out in a second. Sometimes these surgery or these procedures require a certain size of IV that needs to be put into the arm. But of course, remember this, if you only have a little small vein, You can't put a big IV in. Your IV catheter matches the size of the patient's vein. Another assessment would be vital signs, the urine output, the patient's weight, check their skin turgor, and listen to their breath sounds. Crackles could indicate a fluid overload. And you want to check here on the side of the neck for jugular vein distension and also check for edema. We talked a bit about intermittent or continuous infusions. You would need to know that because when you're preparing your supplies, you'll need to know, do I need to take a bag of normal saline to hang with this intermittent IV medication, or will it be continuously infusing? When we initiate IV therapy, we have some expected outcomes. Of course, we want our patient to be free from a vagal reaction when we are starting the IV. So if the patient starts to sweat and have clammy skin, becomes dizzy or lightheaded, their ears may start ringing, having pale skin, nausea or blood vision, these are all signs and symptoms of a vagal reaction. So you may have to stop the procedure, allow the patient to recover, and get a set of vital signs. After initiating IV therapy, our expected outcome is that they will not have a fluid and electrolyte imbalance, but all will be balanced. So we have to keep an accurate I&O record that's for intake and output. So what comes in needs to come out. It needs to be balanced. We want the patient to remain free from IV complications such as phlebitis, infiltration, infection, an air embolus. And before we go any further with some of these expected outcomes or complications, let me talk a little bit more about the air. Many facilities use pumps, and this is not going to be a major problem because these pumps are so sensitive to air. If a little air bubble gets into that line, it is going to alarm and it will not run. In fact, I have had an IV pump saying, air in line, and I have looked with my eyes and I cannot find an air bubble. So it has to be really, really tiny, and I cannot find it. So in this particular instance that I'm remembering, I had to completely just take the tubing off of the pump and just let the fluid run through and had to waste a few mils of it. And then put the line back on the pump, turned it on, and it worked fine. But I never did see that bubble. When you get an air bubble in your IV tubing, it's like a foreign body, something foreign in your blood, because air does not belong there. And this air bubble then becomes coated with platelets, with white blood cells, with some protein, because your body is doing a reaction. The defense mechanism is put into place. So now you have got an air bubble with this nice coat on now, traveling in your circulation system. Now when it gets to the micro system with the capillaries, it may be too large to even go through the capillary and block that off. And then over time, that air bubble with its nice coat on may break down and be able to travel into the arterial circulation. And this one we have really serious complications. Can have a stroke, memory loss, confusion, just depending on where this air bubble is at. I don't have the figures in front of me, but there is I'm thinking maybe a half to a milliliter of air that finds itself into the brain can cause death. And I know there's a particular amount that I have read in medical journals, in some research studies, that a particular amount, if it finds itself in the pulmonary vein, can have a heart attack. So air bubbles are very important in the fact that we need to not see them in our IV lines. And we take a lot of care and go to a lot of trouble to prime our tubes and making sure there's no air. It's in your protocols at your facilities. Yet, oftentimes, you will hear a patient ask, nurse, I see an air bubble coming down my tube. Is that going to hurt anything? And you may hear that nurse say, oh, that's just such a little tiny bubble. That's not going to hurt anything at all. But I want you to remember that yes, any air bubble is a foreign object to your body. It does not belong in your circulation system. And you could have possible complications. To lower the risk of getting air, you want to start the IV with the patient's arm below the level of the heart. And you want to keep the IV bags up on a pole above the level of the heart. And if your patient has to go to surgery, has to go down to radiation or to radiology, make sure that you take that fluid on a pole. They have them that attach to the bed, or you have somebody that comes along with you and holds it up in the air. But do not ever lay that bag of fluids on the bed with the patient, because then it's not at above the level of the heart, and you have a real strong risk for getting an air embolus. If a patient starts to have signs and symptoms of an air embolism, which are like being short of breath, coughing, having chest pain, or maybe they're having some changes in their mental status, turn that patient over on his left side and put the bed in Trendelenburg position. So after you do this, you're going to need to call for help. Somebody's going to need to notify the doctor. There's a possibility that you may have to start CPR. Hopefully, and this is not easy, but hopefully the doctor will be able to aspirate that air out. Now, if the patient has a central line that's already in, that's like in the subclavian or in the jugular vein, they may be able to aspirate that air from the right atrium, because that's what you're hoping to do when you put that patient in that position, that air will travel up to that right atrium, and then make it a little easier for the doctor to get it from that area. If there's not a central catheter in place already, then that's going to be harder for the doctor to have to insert something and try to aspirate the air out. So it would be much better to prevent the risk of air embolisms than to have to deal with one. Okay, now then, I get off my soapbox about the air in the tubing. I certainly don't want air in my tubing, and I don't want air in my patient's tubing. And I hope that'll be your goal too, is to never have any bubble, no matter what size, no matter how small, to always have tubing that's free of bubbles. Okay, now let's get back to our expectations. We want our patient to be comfortable with minimal restrictions. Ask them about whether they're left-handed or right-handed, because that will make a difference. Maybe if you can choose which side to put the IV in. And then, of course, you're going to know, are they going to be getting up to the bathroom or not? So these are things to consider. Maybe you would like to put a saline lock in if you know that they are going to be getting up and down. That way you can disconnect their IV while they go to the bathroom. And then when they come back, you can reconnect it. Now, if you're following along in your handout, I'm going to skip the section for inserting an IV because this is already on video for you to watch. And let's go on down now to where it says unexpected outcomes. And I mentioned some of these briefly, but let me tell you a little bit more about it. Okay, phlebitis. Phlebitis is painful, and you will see that the area along the vein will be red. The vein will feel firm, and it can be caused by either a chemical factor, which would be like an irritating med, from a mechanical factor such as the catheter moved, or bacterial. When you started the IV, you may have introduced some bacteria at that site. If you see phlebitis, you will need to remove the IV and notify the physician. Infiltration is like what happened when I was telling about my niece. The IV was not in her vein. All the fluids was going into the tissue surrounding the veins. She got a chemical burn from this. Okay, so if you have infiltration, it normally will feel cool to the touch. It will also be very painful, and it will be swollen. So apply warm compresses. Now, I have read in some articles that you can apply cold or warm, but I usually like to apply a warm compress to an infiltration. The skin is cold, warm it up. That's how I can remember. With the phlebitis, the skin will be warm, and I like to add a cold compress. But you follow your facility's policy on that. So if you've got a site that's infiltrated, certainly you're going to have to remove that IV and elevate the extremity. Depending on the severity of this infiltration, you may or may not have to notify the doctor. Positional IVs, another complication, and this can cause a lot of stress for the patient and for the nurse in trying to tape that IV down in such a way that it continues to, the fluids continue to flow through it. But sometimes it moves just a little bit, and it's like it becomes occluded, and that pump will start alarming. And all you go in there is you touch that IV just a little bit, and there it goes back infusing just fine. And you put a little more reinforcement tape on it, you leave the room, and in about 15 minutes you're going to hear it again. So it's very frustrating to try to maintain a positional IV. You'll have to encourage your patient to move that arm the least amount as possible. If it becomes a real problem, especially for the patient and they just cannot get any sleep, it is just really a high stress for them, consider taking it out and starting a new one. Hematomas. Now this may happen if you blow the vein, and you'll have bleeding under the skin. You'll get a little knot that comes up, and this happens if you've got a fragile vein, and when you stick that needle into that vein and it's under pressure and it's fragile, like I said, it can rupture, and then you're going to have bleeding. So you want to apply pressure to that as soon as possible. Of course, remove the catheter. Infection. Of course, we definitely want to decrease our risk of infection. You may see purulent drainage, some redness or edema at the site, and the patient may have fever and chills, and you would definitely want to remove the IV. It may still be running just fine, very patent, but if it has signs and symptoms of an infection, you must take it out. No matter if it took you 3 hours to finally get one in, you have to take it out and notify the physician. Nerve injury. This does not happen frequently, but it could when you're starting an IV to hit a nerve, to injure a nerve. What happens when it does is because a nurse has inserted the IV catheter and did not get a flashback. So what do they want to do is dig around, to fish around for that vein. In doing so, they may injure a nerve, they may even injure other tissue, maybe even the bone. So be very, very careful and do not do fishing. Just pull the IV back. Do not let it come out of the skin, but just bring it back a bit and then try inserting it at a little different angle. In fact, when you watch the IV initiation start that I did this morning on our mannequin arm, that's exactly what I did, because when I went in, I didn't get a flashback that I was expecting, and I pulled back on it, but didn't remove it all the way out, but pulled back on it and went in just at a little different angle, and you saw it on the video. Nice flashback. Okay, we have to regulate the infusion rate, because we don't want to cause fluid overload, or want to make sure that our medicine and the fluids are infusing at the right time, on time. We talked about the dilaflows earlier today in the video, and I showed you how to count drops and talked a little bit about using a pump. I was looking at IV tubing are classified as either a macro drip or a micro drip. Now the macro drips is what we use today, all that you saw today. And looking on that tubing package, you will see they're usually a drip factor of 10, 15, or 20. I did not have a micro drip to show you, but in the drip chamber, there will be a little tiny needle, and that's where the fluid drips from, and they are always 60 drops a minute. So every micro tubing will be 60 drops a minute. Okay, now we're moving to maintenance of IV sites. And of course, as always, you follow your facility's guidelines. Now, if you come to check it's that 2-hour mark, and you come in to check the IV, and you see that maybe there's some blood or drainage under the dressing, or the dressing is not adhered anymore, or just looks like it needs some care, by all means, go ahead and take that dressing off and redress it. Some facilities want the dressing to be changed like every 3 days, every 5 days. We used to change them much more frequently than we do now, but studies have shown the least amount of time that we are bothering the IV site, the less risk of infection. So you will just use your alcohol wipes and clean that up and apply a new dressing. Now, tubing changes. The primary tubing, the long one that we looked at, those are changed every 96 hours. And then the secondary tubing, if it's interrupted, that will be changed every 24 hours. If a patient is getting TPN, which is the nutrition through the vein, if they're getting that, then that tubing will be changed every 24 hours. The next section on your handout is talking about discontinuing an IV, but again, that's on the video. So let's move and talk just a little bit about IV meds. Of course, administrating an IV med is a high risk to patients, because that medication is in the vein immediately. So side effects can take place, allergic reactions can take place. So this is a very dangerous medication route. But it's good when you need something fast. It's very, very good way to get it into the patient. So it has its pros and its cons. An IV push, and technically an IV bolus is the same thing. However, I will tell you in practice, some doctors, when they want, say, 250, or I've even had one that was 500 mils, they may want to get some fluid very quickly into the patient, and they will say to you, run this, I want an IV bolus of 250 mils of saline. And what they mean is they want you to have that go into that patient as quickly as it will go. But technically, IV bolus and IV push is the same term about just giving that medication like I showed you in an IV push just directly into that catheter. IV push is usually given over 1 to 3 minutes. We talked about that. And we also talked about IV piggybacks. I showed you about the smaller bag being mixed with your medication, and it runs intermittently. Okay. Let me remind you also that when you are given an IV med, you still check your rights. You check for allergies, and you check the patient's labs and their medical history for all those things that I have mentioned earlier. And I believe I said on one of the videos that some of the newer injection ports will not allow you to aspirate. So don't be discouraged if you try to aspirate for blood and it does not come back. But if you can, aspirate, because that is one way to know that your catheter is in the vein. In the handout, you'll see a mnemonic, CATSPR. That's cute, I think. CATSRRR. The C is for compatibility, so you want to make sure that the medication that you're given is compatible to the fluid that's running into that IV tubing. In fact, I have seen crystals form in an IV tubing when the medication was not compatible. So consult your drug book, ask the pharmacist. I know in the hospital where I worked, my last hospital that I worked at, there was a nice chart in the medication room that would have all the compatibilities on it, so that was nice. A is for allergies, so you assess allergies. T, make sure you have the correct tubing, because you need to have long tubing for the primary, short tubing for the secondary. S is site checked. Yes, always keep an eye on that site. How often? At least every 2 hours. Pump. P is for pump. You want to make sure the pump operates. You want to make sure that the battery is charged. You want to make sure it's got its inspection sticker on there and it's in date. So look about your pump just to make sure that it is safe to use. Look at, hopefully if it has been inspected, the cord has been inspected, but it won't take but just a second just to kind of glance at the cord and make sure there's no frayed wires or something poking out of it. R, there's several R's here, so you got R is for right rate, R for release clamps. Remember, it won't infuse if your clamp is clamped. And then the last R is for return and reassess patient. So you know, after you start an IV, after you hang IV fluids, after you hang IV piggybacks, you will be returning to check on that patient. Hello again. As you can see, I took a break and I'm at my house in my lovely garden room. But we're going to go ahead and continue in our handout. Let's talk about central lines. Another route for IV meds and medications is through a central catheter. Up to now, all of our IVs have been peripheral. Those IVs that are in our hands or our arms. Sometimes they can be put in a foot or a leg. I know with infants, that is a common place to find an IV. I did have a lady in ICU who did not have a vein anywhere that I could find on her hands or arms. So I asked the doctor if I could use her leg IV because it was a beautiful vein and you could see it so well. And he gave me permission to do that. Of course, you'll need to talk to your or see about your facility's policies because some places will not allow IVs to be put in the lower extremities because of the high risk of DVTs. And I'll have to tell you a little side note about this particular patient. She was in ICU and had, of course, had one-on-one attention. She was gotten a lot better, so she was moved to the floor. And she told her family that she would put her call light on, but nobody would come to check on her. So she had her family bring a cowbell in. And I am so sorry to say this, that she had to ring her cowbell to get attention for someone to come to her room. But that didn't last but a day because then the family was asked to take the cowbell home because it was very disruptive and annoying to hear cowbell ringing on the hall of the hospital. But I think her point was well taken. Okay, I digress. Let's get back to central catheters. Okay, so I said that they're used for fluids and medications, also to infuse blood products, TPN. Now, if your patient needs to have nutrition through the vein, they will have to have a central line put in. That is the only way that you can deliver TPN. The medical doctor will use the jugular vein, the subclavian vein, or the femoral vein to insert a central cath. As you saw on the video where I accessed my Metaport, I showed you an example of a central cath, and it had the 3 lumens. Central caths may have 1 lumen, or they may have more than 1. A patient who needs frequent blood draws, the doctor may decide to put a central line in so that she's not continuously stuck. Central catheter care requires meticulous sterile technique because it's a high risk of getting blood infections. So when you do care, you will wear a mask and you will put a mask on your patient. And you will do sterile gloving to do cleaning and apply a large transparent dressing. Sites are either cleaned with chlorhexidine, or some doctors still prefer the old method of putting scrubbing it with alcohol and letting that dry, and then applying betadine and letting that dry. But betadine is going to take a couple of minutes for it to dry because it has to be dried thoroughly for it to be effective, and you want it to be dried thoroughly before you dress it. And as with all dressings, you put your date and time and initials. Central catheters are either external or internal. The external catheters, they are tunneled or non-tunneled. Common tunneled catheters are Grosjean, which has a 3-way valve at the tip and does not require heparin or clamping. Now, my Metaport has a Grosjean catheter. Even though you don't supposed to have to clamp, I clamp my needle. One time I was in the shower and my injection port fell down to the bottom of the shower. I have no idea how that happened, and I was so glad that my tubing was clamped. The Broviac catheters and the Hickman catheters, they do not have a valve. They're open just like a straw would be. Hickmans have a little larger diameter, so they are very good to use for patients who need repeated blood draws. Tunneled catheters are there for a long time, and we're talking about months. Now with the internal catheter, that's with the ports, a metaport, a portacap. Those are inserted surgically, and they are intended to be used for years. When I had mine inserted, I was told that they had a patient that had had his for 10 years. There is a limited number of sticks, so I'm not sure if I'm close to that number or not, but I've had mine for 5 years. PICC lines are considered non-tunnel. You may have heard of these, but an MD or a nurse, a specially trained nurse, can put a PICC line in, and it's inserted into the peripheral vein above the anacubical area. Internal devices are surgically implanted beneath the skin. I'm not sure if I said this a little earlier or not, but commonly these are known as metaports or portacavs. These ports have to be accessed with a special non-coring Huber needle, and these ports will last for several years. Like I said, I've had mine for 5 years now, and they just need routine once a month flushing. Mine gets flushed for 3 times a week. So now then, let's move on to drawing blood from a central line. Of course, you're going to always follow your facility's policy and guidelines, because there'll be a special amount of flush that they'll want you to use, and an amount of blood to waste. So you will stop infusions to all the ports, and then you will flush the port that you're going to be drawing the blood from. You'll flush that with normal saline. You will aspirate blood, whatever the number of, it may be 3, 5, 10 mils of blood, and you're going to waste that. Then you will get you another syringe, and you're going to draw back probably 10 mils of blood for the lab tubes. So after you have your blood, then you're going to flush that port again and follow the facility's guidelines. It might be flush with 10 mils, and then you may even have to flush like with 5 mils of heparin. Follow the guidelines. And then after you've got all your blood, you want to restart the infusion. Don't forget about that. Depending on the facility's policy, a nurse may remove a central line. So to do this, you will need to put your patient in a 10 degrees Trendelenburg's position, or you can lay the patient flat if he cannot tolerate his head being a little lower. You will wash your hands and apply gloves to remove the tape in the dressing, and you will inspect the site just as you would if it was a peripheral IV. And then you will put on mask and gloves, and you're going to clean the site. If there's sutures there, and more often than not, the physician will have sutured the catheter in, you will need to get you a sterile suture removal kit. So you remove all the stitches, and then you're going to take a sterile 4x4, and you're going to just place it over the site. Now, while you're doing this, you're going to have the patient take a deep breath and hold. This is called the Valsalva maneuver. You're not going to put any pressure on that 4x4. You're just kind of laying it on top of the site. So you're going to pull out the catheter very slowly and smoothly. But as soon as you get it out, then you want to apply pressure with that 4x4. And you're going to have to apply this pressure for 5 to 10 minutes. So while you are holding that in there, take a look at the catheter. Make sure everything looks like it's intact. Look at the tip. Make sure it's got good integrity. So after 5 to 10 minutes, you can take a peek and see if the bleeding has stopped. So if it has stopped, then you will need to put a petroleum gauze or either some petroleum ointment, whatever your facility policy is. But that you need to put something over that site so there's not a risk of getting air into that vein. So after you have put the petroleum gauze on, you'll cover that with a dry dressing. The catheter will need to be put in a biohazard bag for disposal. Our next section in our handout is on blood transfusions. IV fluids can replace fluid volume and increase blood volume, but they do not restore the oxygen carrying capacity or replace the blood clotting factors in blood. So if a person has experienced a significant amount of blood loss or has a deficiency in one of the blood components, they are given a blood or a blood product. And again, follow the facility's guidelines. Available blood products are whole blood, which is the white blood cells, the red blood cells, and the platelets that are suspended in plasma. You could also give just some packed red cells, and that's good for patients who have a low hematocrit or low hemoglobin level. It'll help bring those values up without giving the patient too much fluid. Plasma is the liquid portion of the blood, and it's made of 90% water. Plasma may be transfused whole, or it can be separated out into albumin, the clotting factors, and immune globulins. Platelets are used to treat patients who have low platelet counts or abnormal clotting function. Platelets help the clotting process by sticking to the lining of the blood vessel. And then our other product to consider is a white blood cells, especially the granulocytes. And these are collected by centrifugation. It's where they put it in that machine that goes around and around and around, and it'll separate the blood. This is very useful for patients who have infections and it's not responding to antibiotic therapy. Before a patient can receive blood or a blood product, they have to have typing and cross-matching done. You have to make sure that the donor blood is compatible to the patient's blood. Human blood is classified into 4 main groups: A, B, AB, and O. And at some point, I want you to look on page 1491 of your textbook. There's a table 39-9, and it's called Blood Groupings for Transfusions. This is very interesting, especially if you know your blood type. Group O is considered a universal donor, and Group AB is the universal recipient. However, blood is also classified into Rh negative or Rh positive. People who have Rh positive can receive blood that's positive or negative. People who have Rh negative can only receive Rh negative blood. So even in an emergency situation, you have to know the blood type and the antigen Rh factor before you can give blood to a patient. Donor blood undergoes various screening tests. Tests for viruses such as HIV, for syphilis, for hepatitis B and C, for a human leukocyte antigen, which is an antibody. Now, these HLA antibodies are common in patients who have had children or have had a pregnancy, and also in patients who have had previous blood infusions. These antibodies are not harmful to you. It's just a natural response to your baby's blood or to the donor's blood. However, if there are HLA antibodies in the blood that you donate, that could be harmful to someone who receives your blood. It can cause a serious condition called transfusion-related acute lung injury. This is where the lungs fill with fluid and it leads to difficult breathing and oftentimes to death. However, sometimes undetected diseases can still be transmitted. Know how much screen tests are done. No blood is completely risk-free. And because of this, some patients will choose to donate their own blood. If they know they're going to be having major surgery in, say, about a month or so, they can go ahead of time, go to a blood donation center and donate their blood, and then it'll be available to use when they have their surgery, just in case they need that blood. That's called an autologous transfusion. Okay, now that's a little bit of background about blood transfusion, about the donor blood. Let's talk about the implementation of a blood transfusion. Of course, you've got to have a doctor's order, and you've got to have written consent from the patient. There may be religious concerns or cultural concerns that will need to be addressed. And you have to verify that there's been a type and cross match done of the patient's blood within 72 hours of the transfusion time. You want to access the patient's transfusion history. Have they had any reactions? If so, you'll need to let the doctor know so that he can order some medications to try to decrease the risk of reactions. So it's very common to see acetaminophen ordered in case the patient has a fever. And sometimes they will order Benadryl to decrease the risk of an allergic reaction, and also a steroid to decrease the risk of inflammation. You want to assess the patency of the IV catheter. This is very important. You don't want to go to the blood bank, get your blood, and come back, and the catheter is not even patent. You can't even get anything to fuse through it, because there is a time limit. Once you go down to the blood bank to get the blood, you have 30 minutes because it's refrigerated, and so you take it out of the refrigerator, you'll compare a lot of paperwork, make sure you got the right blood for the right patient, come back up to the patient's room, and you have 30 minutes to get that blood infusing. If not, you have to take it back to the blood bank. So go ahead and assess the patient's vital signs so that you have a baseline to go by. If the temperature is more than 100, you'll need to call the doctor because he may want to postpone giving the blood transfusion. You'll need to look and see what the patient's IV med schedule is, because you want to time this so that there's not any interruption if possible. Whole blood may take up to 4 hours to infuse, and that is the maximum time. You cannot allow whole blood or packed red blood cells to hang more than 4 hours because of the increased risk of infection. So you'll need to gather your equipment. You'll need the blood administration set with a filter, and you'll need a 250 ml bag of normal saline. You cannot use any other kind of IV fluid because it will break down the blood cells. And remember, the normal saline is about the same osmolarity of the blood. So that's the choice that you want to use, that you must use. You'll need to have clean gloves to wear because when you're handling blood products, you need to have gloves on. You will need an IV pole, an infusion pump that's been approved for giving blood transfusions, and you may even need a blood warmer. Blood warmers decrease the risk of blood reactions, decreases the risk of hypothermia and heart arrhythmias. If you are given blood into a small catheter, such as a 24 gauge that you might see in a frail elderly person or in a child, you will use gravity infusion. Not always, but most of the time you will not be using a pump, but you will be infusing by gravity. So after the assessments are completed and your pre-transfusion meds, if any, are given, and you've got all your equipment ready to go, that's when you go down to the blood bank to get your blood product. When you get back, you're going to have to verify this product. There's a lot of paperwork attached to it, and you'll go to the bedside with another licensed nurse. And you will compare the name on the patient's armband to the name on the blood, to the name on the paperwork, and you will be looking at the hospital number, the blood bank number, and you will be inspecting the blood, make sure it's the right color, that it doesn't have leaks in the bag, and there's no clots in it. So you've got a lot to do within your 30-minute time frame. Of course, one of the most important things to do, other than the right patient, you've got to make sure it's the right blood type. So that will be a very important consideration, which type it is and which RH factor it is. And you want to look at the expiration date. And then when you do prime your blood administration set with your saline, and then you put your blood and it's going, you want to make a note of what time that your blood infusion started, because that time will also be on the paperwork that will go back to the blood bank. You'll want the patient to void. If they have a Foley catheter in, you'll want to empty that, because if they happen to have a reaction, oftentimes the doctor will want a urine specimen to be sent to the lab, because sometimes that kind of helps them to analyze what has caused this reaction. So the first voided urine, and you may even have to use a straight catheter to get a urine sample if there's not a Foley catheter already in. So you'll have your wash your hands, and you'll have gloves on, and you get your administration set all ready to go. And I don't think I mentioned that you will invert the blood 2 or 3 times. You want to get it mixed well. Now I think we're ready to attach it, and you're going to remember to scrub the injection port really good with some alcohol. And you're going to set the rate at 10 to 20 drops per minute if it's infusing by gravity. If you've got it on a pump, you will set that to 50 mils an hour. And you're going to stay with and that will be for the first 15 minutes. You want a slow infusion rate. And you've gotten your baseline vital signs. So you're going to plan to stay with this patient for the first 15 minutes. So after 5 minutes, you'll take vital signs again. After another 5 minutes, another set of vital signs. And then after 15 minutes, you'll have your last set of vital signs while you have to stay in the room. Now, if during that time your patient has a reaction, you have to immediately stop the infusion. And you're going to call for help, because there's a lot of things that's got to be done now. You're going to need to start take all that bloody tubing off, and you're going to try to maintain that IV catheter and put up a new bag of normal saline to go into the IV line that is established. And if your patient's having a reaction, you're going to have to also be taking care of the patient and notifying the physician and taking vital signs again. And if you look on page 1492 in your textbook, there's a table there that describes types of transfusion reactions, and there's signs and symptoms of each, and what the nursing responsibility is for that particular reaction. Now, you need to let the patient know that he is to report if he has itching and swelling, dizziness, low back pain, chest pain. So if anything out of the ordinary transpires in that first 15 minutes, he is to let you know, or you may even observe it. But even after the first 15 minutes, you want him to be aware of these symptoms to look for, because there can be a delayed hemolytic reaction. Okay, now let's go back to the first 15 minutes, and let's assume that the patient does not have a reaction. We hope your patient does not have a reaction. So you have been taking the vital signs every 5 minutes times 3. So now you can increase your infusion rate. Depending on what your blood product is, depending on what your facility's guidelines of when that particular blood product has to go in, then you know how fast you need to run your, put your rate on your drop by gravity or on your pump, so that you get your blood product in the correct time. Okay, in the next 15 minutes, you'll take vital signs again. In the next 30, you'll take them again, and then hourly after that. But again, follow your facility's policy, because that will tell you how often you take vital signs. You will need to, again, reinforce these signs and symptoms with your patient and the patient's family, because these reactions can even take place up to 2 weeks after the blood transfusion. So your patient may be at home and have a reaction. So that family needs to be aware, and that patient needs to be aware. After the blood transfusion is complete, you want to clamp off the tubing, and let me back up. After it's complete, you want to clamp the blood tubing. Remember, it's on a Y, so you've got saline on one side, blood on the other. So clamp the blood bag, and then you're going to open up your saline and let that run through and give it a good flush. You want to clear the tubing completely of the blood, and then let it run for a little bit longer, because given blood products is a high risk for phlebitis. So really flushing out that vein will be good to prevent phlebitis. Leave it at a KVO rate, which is 20 to 30 mils. Okay, I think that's all. That gets us to the end of our handout, and so we're done. And if you have any questions, just write that down on a piece of paper, because I hope that we'll have a Zoom meeting at some point, and we'll be able to answer your questions. And so until then, until we see you in July, goodbye and stay well, and God bless.